All right, let's jump right into this next case. We've got a 68-year-old woman presenting with thoracic back pain, which she says is worse at night. There's a bit of a history here. She had breast cancer about 5 years ago, so that immediately raises some flags in terms of potential for metastasis, but let's not get ahead of ourselves just yet. She denies any recent trauma, which rules out an acute injury. Now, the clinical background sets us up for a deeper look into what's happening. So let's dive into the imaging findings to try to piece together what's going on. We begin with a lateral radiograph of the thoracic spine. What strikes me here is the presence of sclerosis in the mid-thoracic vertebral body, which is extending into the pedicle. The vertebral body is losing height. There's vertebral body collapse, suggesting a compression fracture. But it's the sclerosis that's most concerning, particularly given her history. Sclerosis often hints at the presence of a secondary malignant process, especially in this case where there's a prior history of breast cancer. We also see areas of sclerosis in the posterior aspect of the superior vertebral body. There's also something subtle here, but worth noting. The cortex around the sclerosis is ill-defined. This ill definition usually speaks to some degree of bone destruction, which is consistent with aggressive lesions, possibly metastases. And that fits the clinical context. So this radiograph already sets the stage for us to think about a malignant cause, but we've got more imaging to consider. Next, we move on to the CT thorax. This is on bone windows, and what stands out is the presence of additional areas of bone destruction in the vertebrae. There's an associated soft tissue mass seen on the CT, which raises further suspicion. Again, we're seeing the cortex of the vertebra being breached, further pointing us in the direction of metastases. Bone metastases from breast carcinoma are typically sclerotic, but the presence of a soft tissue mass adds complexity, making us think of potential spread beyond the bone. Finally, we take a look at the T1-weighted MRI of the thoracic spine. Here, multiple areas of low signal intensities jump out in several of the thoracic vertebral bodies. The anterior and posterior elements are involved, which is highly suggestive of a malignant process. Now, what I find particularly interesting is that while the spinal cord appears intact, there's no visible compression at this point, the low signal on the T1-weighted sequence likely represents the tumor replacing the normal fatty bone marrow. That explains the low signal. These findings, the bone destruction, the soft tissue mass, and the T1 signal changes, all point us toward metastatic disease. Given her previous history of breast cancer, it's highly likely that these represent sclerotic metastases from the breast carcinoma. Now, as we know, breast carcinoma tends to produce sclerotic bone metastases, and we're seeing that classic pattern here. So what's our differential? Well, in this case, lymphoma would be on the list, especially if we were seeing more lytic lesions. But that's not the dominant pattern here. Lytic metastases could also come into play, especially post-radiotherapy or chemotherapy, but again, given the sclerosis, those are less likely. Other considerations could be multiple myeloma, but remember that multiple myeloma usually produces more widespread marrow involvement, and we're not seeing that typical diffuse marrow pattern here. In terms of management, we need to take a comprehensive approach. The entire spine should be imaged with MRI, axial and sagittal T1-weighted, T2-weighted, and STIR sequences to assess the extent of disease and to ensure there's no cord compression. If the spinal cord is compressed, this patient will require urgent intervention, whether it's radiotherapy or surgical decompression. Additionally, the rest of the skeleton should be imaged with a bone scan, such as a 99-MeTC MDP bone scan, to evaluate for other areas of metastatic disease. Skeletal metastases are a key concern here, and they often follow a recognizable pattern on imaging. On plain radiographs, you look for bone destruction involving the posterior elements, bony sclerosis, or lytic areas, depending on the primary carcinoma involved. In this case, multiple bones could be involved, and we should be cautious of pathological fractures and collapse, as we've already seen vertebral body height loss. We can use CT to better define these areas of bone destruction, and what we're likely to see is a combination of ill-defined cortex, possibly with soft tissue masses associated with the metastases. High-resolution CT with bony reconstruction can be incredibly useful here for surgical planning and further management decisions. MRI plays an essential role in this case for assessing marrow infiltration. We've already discussed how the bone marrow signal on MRI is affected by age and other factors, but what's critical here is the identification of red and yellow marrow changes that could indicate tumor infiltration. In metastatic disease, we typically see low signal on T1-weighted sequences compared with muscle signal. And that's exactly what we've noted. It's also important to differentiate between normal marrow changes and pathological findings. STIR sequences and fat saturation sequences can help to suppress the normal fatty marrow signal, making the areas of high signal infiltration stand out. In this case, the red marrow on STAR will show a slightly increased signal compared to muscle, but metastatic disease will show areas of high signal on T2-weighted sequences. Contrast-enhanced imaging is useful for delineating the full extent of the disease, as metastatic disease typically enhances with IV contrast. As always, multiple modalities are critical in the evaluation and management of metastatic disease. From radiographs to CT and MRI, each plays a role in guiding us toward a definitive diagnosis and helping us develop an appropriate management plan. Thank you for joining me in this discussion. If you found this breakdown helpful and want to explore more fascinating cases in radiology, don't forget to subscribe to Radiology Made Easy. If you'd like to support our work and keep the content coming, check out the Buy Me a Coffee link in the description. Your contributions help us continue sharing these insightful discussions. Thanks again for listening, and I'll see you in the next case.